Acute pancreatitis. So first important question that is asked with respect to your acute pancreatitis is regarding the possible causes of acute pancreatitis. So I have taken this table from your Bailey and Love. The various causes of your acute pancreatitis includes your gallstones, alcoholism, post-ERCP, abdominal trauma following biliary or upper GI thoracic surgery, ampullary tumor, drugs like corticosteroids, azathioprine, asparaginase, valproic acid, thiazides and estrogens, right. Then hyperparathyroidism, hypercalcemia, hypertriglyceridemia, pancreas divisum, sphincter of Oddi dysfunction, autoimmune pancreatitis, hereditary pancreatitis and viral infection like mumps and Coxsackie B virus, malnutrition, scorpion bite and idiopathic. Now, if you are asked regarding one of the most common causes, then it is your gallstone, right. So, gallstone is your more important cause compared to your alcohol. Now, remember, for gallstone pancreatitis, the surgery should be done in the same hospital admission, right. So, this is one of the very important questions that is asked. Now, regarding the clinical features, so the pain is the cardinal symptom of your acute pancreatitis. It is usually experienced in the epigastric region and approximately around 50% there is radiation to the back, right, and this is classically relieved by stooping forwards. So, when you see a patient in your emergency setup where the patient complains of an epigastric pain and gives a classical history that the pain is relieved on stooping forward, it gives your hint towards the acute pancreatitis. Then it may be associated with your nausea, vomiting, and then obviously with pancreatitis there would be other features of clinical shock that might be presenting, and on examination there might be tenderness or rigidity in your epigastric region, right. And other specific features seen with respect to your acute pancreatitis include your bluish discoloration of the flank, which is known as your Gray Turner sign, and then we have your bluish discoloration over the umbilicus, which is known as your Cullen's sign, right. Then regarding the investigation, we have your amylase and lipase, right. Please remember that lipase is more sensitive and specific when compared to your amylase, and a positive amylase does not means that it is pancreatitis, as amylase can be raised in many other cases also. Then what are the cases when you would want to do a CT scan in case of acute pancreatitis, right. So, when the diagnosis is uncertain, then distinguish the interstitial and your necrotic form. Then when your local complications are suspected, and you would also do a CT scan when the patient is presenting you with sepsis or your organ failure, right. Now, in acute pancreatitis there are various severity scoring system which includes your Ranson, Glasgow, Apache, SAPS, SOFA and MODS. So, the most important that we would be discussing is your Ranson and Glasgow. So, first we discuss the Ranson. So, Ranson has it basically checks your severity at 2 points, one which is on admission and second within your 48 hours. So, on admission, what are the parameters? It includes age more than 55 years, white blood cell count more than 16 into 10 to the power 9 liters, blood glucose more than 200 milligram or more than 11 millimole per liter. Then we have LDH more than 350 units per liter and AST more than 250 units per liter. Then within 48 hours, there should be a fall of at least 10 or more in hematocrit. Blood urea nitrogen is raised more than 5 milligram per deciliter. A partial pressure of oxygen is less than 60 mm of Hg. Serum calcium is less than 8 mg per deciliter. Base deficit is more than 4 millimole per liter and fluid sequestration of more than 6 liters, right. Whereas in your Glasgow criteria, which is done within 48 hours, right? You have this following parameters: age more than 55, white blood cell count more than 15 into 10 to the power 9, whereas in case of Ranson it was 16, blood glucose more than 10, whereas in Ranson it was more than 11. Then we have LDH more than 600, whereas in case of Ranson it was 350, AST more than 200, whereas in Ranson it was more than 250. Then we have your serum urea more than 16 millimole per liter, PaO2 less than 60 mm of Hg, serum calcium less than 2 millimole per liter, and serum albumin less than 32 gram per liter, right. So, these are your severity scoring system. Then we have an Atlanta classification for your acute pancreatitis. So, what is this Atlanta classification? It classifies pancreatitis into 3 types, which include your mild acute pancreatitis, moderately severe acute pancreatitis, and severe acute pancreatitis. So, what happens in your mild acute pancreatitis? So, there is no organ failure and no local or systemic complications. Now, what happens in your moderately severe acute pancreatitis? So, there is an organ failure which resolves within 48 hours, right. So, it is not a persisting organ failure which resolves within 48 hours, and then there may be local or systemic complications without organ failure, right. So, there is no organ failure along with the local or the systemic complications. Now, in severe acute pancreatitis, we have a persistent organ failure. Now, what is this persistent organ failure? It is more than 48 hours. Then you have your single organ failure or your multiple organ failure, right. Now, regarding the early management of your severe acute pancreatitis, I have again taken this table from your textbook Bailey and Love. So, it includes your admission to your high dependency unit or ICU, analgesia, aggressive fluid rehydration is needed, supplemental oxygen, then your invasive monitoring of your vital signs, central venous pressure and urine output and blood gases, then your frequent monitoring of hematological and biochemical parameters including the liver and the renal function, clotting and the serum calcium and blood glucose. Then we have your nasogastric tube only initially, then that means we do not have to have a persistent nasogastric tube. Then antibiotics only if cholangitis is suspected, and then prophylactic antibiotics can be considered, and usually we give antibiotics only when we suspect an infection. The CT scan essential if there is organ failure or clinical deterioration or signs of sepsis develop. Then ERCP within 72 hours of severe gallstone pancreatitis or signs of cholangitis. Then your supportive therapy for organ failure if it develops, and nutritional support is required, and we need to consider early enteral feeding or at least a nasogastric feeding, right. So, these are your early management guidelines of your acute pancreatitis. Now, again we have a next table that I have taken from your Bailey and Love, which includes the complications of acute pancreatitis. So, the main complications of acute pancreatitis could be divided into 2 groups, that is systemic and local. Your local complications include your peripancreatic fluid collection, sterile pancreatic necrosis, infected pancreatic necrosis, pancreatic abscess, pseudocyst, pancreatic ascites, pleural effusion, portal or splenic vein thrombosis and pseudoaneurysm, whereas your systemic complications include your cardiovascular, shock arrhythmia, pulmonary ARDS, renal failure, hematological, which includes your disseminated intravascular coagulation. Then you have your metabolic abnormalities that include hypocalcemia, hyperglycemia and hyperlipidemia. Then it could have a post-op ileus, and in neurological it could have your visual disturbances, confusion and encephalopathy, and miscellaneous complications include your subcutaneous fat necrosis and arthralgia. So, this is all about your acute pancreatitis. Now, in the next video of your acute pancreatitis, we shall be discussing in details regarding the complications of your acute pancreatitis, which would include your pancreatic necrosis and your pseudocyst. So we continue our discussion on acute pancreatitis. So there's some revised definitions for the morphological features of acute pancreatitis as per the Atlanta classification. So first we have the interstitial edematous pancreatitis. In this, there's an acute inflammation of the pancreatic parenchyma and the peripancreatic tissue, but without any tissue necrosis. Right? There is no tissue necrosis. Then we have your necrotizing pancreatitis. This is an inflammation associated with the pancreatic parenchymal necrosis and or along with peripancreatic necrosis. So the main difference between your interstitial edematous pancreatitis and your necrotizing pancreatitis is the presence of necrosis in your necrotizing pancreatitis. Then we have your acute peripancreatic fluid collection. So this is peripancreatic fluid associated with interstitial edematous pancreatitis with no associated peripancreatic necrosis and applies to areas of peripancreatic fluid seen in first 3 weeks after onset of interstitial edematous pancreatitis and without any features of pseudocyst. So this is about your acute peripancreatic fluid collection when there is no pancreatic necrosis seen in first 3 weeks after your interstitial edematous pancreatitis and no features of your pseudocyst. Then we have your pancreatic pseudocyst. So this is an encapsulated collection of fluid with well defined inflammatory wall. So the inflammatory walls are well defined and they are usually outside the pancreas with minimal or no necrosis, right? And it occurs when more than 4 weeks after the onset of interstitial edematous pancreatitis. So your acute peripancreatic fluid collection is occurring after 3 weeks, whereas your pancreatic pseudocyst is occurring after your 4 weeks of onset of interstitial edematous pancreatitis. Then we have your acute necrotic collection. So this is the collection containing your variable amount of fluid and necrosis, which is associated with your necrotizing pancreatitis. Now this necrosis can involve pancreatic parenchyma as well as your peripancreatic tissues. Then we have this walled off necrosis. Now this is a mature encapsulated collection of pancreatic or peripancreatic necrosis that has developed a well defined inflammatory wall and it is occurring usually after your 4 weeks of onset of necrotizing pancreatitis. So this is almost the same counterpart of your pancreatic pseudocyst, which is occurring after 4 weeks of interstitial edematous pancreatitis. Right. Now a few important points regarding your pancreatic necrosis. It refers to your diffuse or focal area of non-viable parenchyma. Right. Now it is identified by the absence of parenchymal enhancement of CT with IV control. It is associated with your lysis of peripancreatic fat. Now, infected necrosis is associated with a mortality rate of around 50%. Now, regarding the management of this necrotic material, now we check whether the necrotic material is sterile. If it is sterile, then it needs not be drained. Whereas, if the necrotic material and the patient shows sign of sepsis, then the aspiration of the fluid with a fine needle under a CT guidance or an ultrasonographic guidance is needed to determine if it is infected, right? And the drainage of infected fluid is carried out. So we have the CT image over here, which is demonstrating a infected necrotic material in your pancreas, right? Now how will you go and proceed about the management of this pancreatic necrosis? So first we need to do an internal drainage into the stomach under the endoscopic ultrasound guidance. Now if this fails, then we move towards your percutaneous drainage, right? And the aspirate should be sent for your microbiological assessment and this antibiotics should be started as per your culture sensitivity. Now, if the patient still worsens, then we need to do a pancreatic necrosectomy. Now, depending upon the area which is involved, if the head is involved, then a midline approach is preferred, whereas if a body or tail is involved, then a retroperitoneal approach is taken. Now, in your management, a feeding jejunostomy may be used as an adjunct, and if there is a gallstone pancreatitis, which was the main cause of your necrotizing pancreatitis, your cholecystectomy should be done. Now, post completion of necrosectomy, what happens is that the further necrotic tissue may form. So, in order to manage this, the various modes of treatment are your close continuous lavage. So, what happens in this is that the tube drains are left in and the ROM area are flush. So, this is an example of your continuous post-operative close lavage, where your tube area is left and a continuous post-operative flushing is done. Then we have this closed drainage. So, what happens in your closed drainage, your incision is closed and your cavity is packed with gauge-filled Penrose drain and a closed suction is applied. Then we have an open packing. So, this incision is left open and the cavity is packed with the intention of returning to operating room at regular interval and repacking until clear granulation cavity is seen. Then lastly, we have your closure and relaparotomy. So, where the incision is closed and the patient is taken to the operating room every 48 to 72 hours for a relaparotomy until you find your clear granulation cavity. So, this was in your post-op necrosectomy patients. Now, a few points regarding your pancreatic abscess. So, these are circumscribed intra-abdominal collection in the proximity of pancreas, right, and it is mainly your walled-off necrosis or your acute necrotic collection that becomes infected. Now, pancreatic ascites, it is associated with your duct disruption. Then a paracentesis would give you a turbid fluid with your high amylase level. Then the treatment is your adequate drainage with your wide bore drains. So, always remember that whenever you are applying your drains over here in case of a pancreatic necrosectomy, please make sure that you use a wide bore drains. And then regarding a few points regarding your pancreatic pseudocyst. So, this is a CT image showing your pancreatic pseudocyst over here, and this is your stomach which is being displaced upwards, right. Now, the fluid characteristics of your pancreatic pseudocyst include your low CE level, inflammatory cells and high amylase levels. Then regarding the management of pseudocyst, now once the pseudocyst attain a size of more than 6 cm, if it is asymptomatic and not enlarging, then we can observe the patient. Whereas if it is symptomatic or enlarging, then we need to do a magnetic resonance cholangiopancreatography or endoscopic retrograde cholangiopancreatography and see if there is a communication in the duct or any stricture or the duct is normal. In case of a presence of communication, you would need to do an endoscopic transpapillary drainage. In case of a stricture, you would need an endoscopic internal drainage, and also in the case of a normal duct. Now, if this fails, then we go for your surgical internal drainage or your resection, right. The surgeries usually performed are your cystogastrostomy, and in few cases we even do a cystojejunostomy. Now, regarding your complications of your pseudocyst, so I have taken this table from your Bailey and Love. So, the various possible complications of a pancreatic pseudocyst include your infection, where it can form an abscess or systemic sepsis, and the rupture of the cyst into the gut can cause your gastrointestinal bleeding or internal fistula into your peritoneum can cause your peritonitis. Now, because of the enlargement, the pressure effects, the obstructive jaundice from a biliary decompression may occur, or it may lead to your bowel obstruction. Then it can cause pain, and erosion into a vessel would lead to hemorrhage into the cyst and hemoperitoneum. So, with this we come to the end of the discussion of acute pancreatitis. Thank you.